Well, good afternoon and good evening to a truly Pan American conference. From our colleagues in Hawaii to those on the East Coast, we're spanning 6 time zones, so the sun almost never sets on the American College of Radiology. My name is Johnson Lightfoot, and as chair of the Commission for Women and Diversity, we are pleased to co sponsor this very valuable and unique webinar. This coronavirus pandemic has exposed, amplified, and magnified health and economic disparities throughout our society. We'll examine today the additional adverse impact of divergent guidelines for breast screening as promulgated by various agencies upon our diverse national population, and especially in Hawaii, which is our most diverse state. These guidelines underserve many of our populations and exacerbate health and outcomes disparities. Many thanks to our expert and thoughtful panelists, and especially for our audience for attending and offering both questions and answers later this afternoon and evening. Welcome.
Hi, I'm Dana Smetherman, and I am the chair of the Commission on Breast Imaging for the American College of Radiology. And I am just delighted to be able to have the Breast Commission co-host this really, really exciting event with my colleague, Dr. Lightfoot. When we were asked about if we would be willing to partner with the Hawaiian Radiological Society to host this webinar, I was so excited because I really think as we stand here on the eve of a very, very different October, I really feel that given the pandemic and everything else that's going on, there has been such a light shown on health inequities that having the opportunity to have such a really, really well-informed and interesting group of panelists to take us through some of those issues is a tremendous opportunity. So thank you again for giving me the chance to even be a part of it and for our Breast Commission to be a part of this really exciting webinar.
Hi, everyone. My name is Dr. Ramya Srinivasan. I'm a radiologist in Kauai, and I am happy to moderate this along with my colleague, Lisa Ignacio. So first, I'd like to thank the ACR, and particularly Dr. Lightfoot and Dr. Smetherman, for their support in getting all of this going. And as you both said, it's a really important and timely topic given, the state of our country right now. So I'm really glad we get to discuss this locally and on a national level. So thank you everyone in the audience for taking the time to participate. So we're going to start off with Zara Khan. She's an executive director for strategic planning, and she's an advocate for racial health equality and particularly minority women. Her recent article, Systemic Racism in Mammogram Guidelines, which I'm sure a lot of you are familiar with, got a lot of attention nationally and probably around the world, and was really one of the big impetus for getting this discussion started. So thank you, Zara. I'll turn it to you.
My pleasure. Just want to make sure we can all see my screens here. Aloha, everyone. Thanks so much for joining me, and I truly hope that you are all safe during these challenging times. I want to give a big thanks to Dr. Scott Grosskreutz, President of Hawaii Radiological Society, his entire team, Dr. Lightfoot, and the ACR Commission for Women and Diversity, and all of you for inviting me to come and speak today on 3 things: my personal mammogram screening journey, my work on mammogram equity, and a review of the flawed United States Preventive Services Task Force mammogram guidelines. So these guidelines suggesting that all average risk women begin screening at age 50, they really racially disadvantage Blacks, Asians, and Hispanics whose breast cancer diagnosis typically peaks in the 40s. And by ignoring critical race data for minorities, these guidelines are creating a deep racial injustice for these ethnic groups. So all the references and data that I'm going to be talking about today can pretty much be found in this article that I have on this screen, Systemic Racism and Mammogram Guidelines. And you can go through the hyperlinks and you'll be able to get to all the references. So I won't be enumerating them in all my work and slides going forward. This is the slide that will give you all of that data reference. Anyways, all this to say, I am so truly honored to be here with you today, healthy and well, thanks to annual screenings in the 40s. For me, 2018 was a totally different story. Shortly after the new year, most of my resolutions turned into background noise as I focused instead on prayer while undergoing several tests, getting concerning results, all stemming from an abnormal routine mammogram screening. My younger daughter was just an 8th grader in middle school, and my older teenager was home from college, and both of them were deeply shaken. They slept with me every night for the first couple of days, worried that our expected lifetime together was becoming very uncertain. My husband of almost 22 years not only showered me with the utmost love and care, but also being a physician was able to help me navigate difficult choices with compassion and dignity. After all, a woman in the 40s really needs to have that chance to make life a quality, full life for herself and her family. We are often in energetic roles as moms, wives, workers, and community members. We are not elderly. We're in the midst of our lives, often with dependent children. Consequently, my family will always remember the start of 2018 as that time that mom thankfully dodged breast cancer. However, to this day, I am deeply haunted by how close I came to making the wrong decision that year and how it would have deprived me of that chance of becoming a breast cancer dodger. During my annual physical, my PCP had really tried to explain to me that someone who's in her 40s, who has no family history, has no lifestyle risk factors, has no palpable lump, and had a clear mammogram the year before, really does not need to go for a mammogram again because the US Task Force guidelines really recommend women like myself, average risk women, to wait several more years until they turn 50 to even begin screening. And feeling on the fence with this advice, I just decided at the end to act on my own inner premonition, my own instinct, and I requested her for a mammogram just one more time. And my PCP ultimately deferred to my wish for a 3D mammogram, which actually produces very high quality imaging, 40% better imaging than a regular mammogram for women who might have dense breast tissue, which is often present in women in the 40s who are slim and have not yet gone through menopause. So I went for this test, and a few weeks later, my family, my friends, and my community were truly shocked when I shared my stage 0 precancer diagnosis, visible only as a tiny, tiny microscopic scratch on a screen. And a comparison to my prior year mammogram confirmed that this was definitely a new development. Unlike true cancers at stages 1 through 4, a stage 0 abnormal precancer cell, as we all know, does not have the developmental capacity to move or invade into surrounding tissue yet. So the timing of this catch was really crucial. One good outcome of me sharing this very, very private part of my life and my private results was that many of my acquaintances went immediately for their own mammogram screenings. And for that reason, I continue to share my story with all of you. Suddenly, I was a case in point for all of them about why leading cancer institutions like MD Anderson, Sloan Memorial Kettering, the American Society of Breast Surgeons, and the ACR all recommend mammograms start at age 40 and continue annually because new abnormal tissue changes can occur in just 1 year. because stage 0 is a precancer, this stage is often not focused upon, and yet it is such an important stage because it is the stage where you uniquely dodge breast cancer, true invasive breast cancer, stages 1 through 4. And true invasive breast cancer tells us that 1 in 6 women actually does get diagnosed in the 40s. 1 in 8 women gets afflicted in her lifetime, and 75% of the women are diagnosed without any family history and without being high risk. And this was a very important fact for me because the family history part is so over-advertised that women have stopped realizing that a majority of people do not have family history and do not have high risk. So at stage 0, a woman has even more options. It's the most unique opportunity to dodge invasive breast cancer without harsher treatments. And it includes options like surgical routes that do not require chemotherapy, radiation, or long-term daily drug usage. Honestly, never before had I been so relieved to get a complete 0 for a test. Thanks to annual mammogram screenings, I'm lucky to identify myself and count myself as someone who dodged breast cancer, a breast cancer dodger rather than a breast cancer survivor. But in trying to make sense of this journey and understanding what had happened, I had to ask myself again, how could someone in the 40s with no family history, no lifestyle risk factors, and a clear mammogram just a year before be diagnosed even with a precancer? I began to wonder if my outcome was not an uncommon one, and if so, how could the task force guidelines have really pushed all average risk women to wait until age 50 to even begin screenings, and to even then ask them to do those biannually when I had just discovered, as many women do, that abnormal tissue changes can occur in just 1 year. How did this make sense? What were the cost and policy implications here? So seeking answers, I turned to the areas that I know best with my expertise: finance, data, policy. And in parsing through websites, testimonials, research papers, and archived government documents, I found myself uncovering a much deeper message that needed to be shared and articulated from a racial injustice perspective. That the task force guidelines to start mammograms at age 50 are racially unjust because they disproportionately disadvantage minority women in their 40s. According to a major Harvard study, unlike white women whose breast cancer diagnoses typically peaks in the 60s, breast cancer diagnoses for minorities, including Blacks, Asians, and Hispanics, peaks in the 40s. So to begin mammogram screening, if we look at this graphically, it's really clear. To start at 50 leaves all these minorities behind. So I was proud of this graphic I created. I wanted something simple that looked like a flatten the curve. And I hope this conveys what I'm talking about in a simple little graph, that mammogram inequity occurs because these guidelines are leaving women behind. And they leave women behind because they ignore critical age-related breast data. And so in examining these guidelines, I started looking at the arguments. And I realized that the task force guidelines really create fallacious perceptions with most of their arguments, misapplying 4 key concepts for women in the 40s. And these 4, I think, are worth exploring together. They're overdiagnosis, false positives, mortality, and cost. So if we look at overdiagnosis, this is the idea that creates this uplifting notion, because it makes people believe that treatment may not be needed for all cancers, since autopsies do occasionally discover an asymptomatic cancer in women that would have never affected a woman's life. And this might be true for a slow-growing cancer for a woman who's really elderly and near the end of her life expectancy. However, it is irresponsible to suggest that precancers and cancers can be left untreated or overdiagnosed in the 40s, because breast cancers in younger women tend to be more aggressive. Therefore, overdiagnosis is a completely hollow argument, because for the 40s, missing a potentially aggressive malignancy would have devastating life expectancy consequences. The second argument, false positives, is referred to as a principal harm. False positives are suspected lesions in mammograms, which upon subsequent testing prove to be benign. In reality, 87% of all mammograms find accurate findings. So calling false positives a principal harm is pretty baffling. And furthermore, in the 40s, as I'd mentioned earlier, 3D mammograms provide a 40% better detection rate. So this argument also just doesn't make sense. The third argument the task force uses is mortality data. But by over-relying on mortality data and losing focus of just as important, if not more at times, the critical quality of life improvements, the task force deprives us of the chance to catch an abnormality early at stage 0 to dodge harsher treatments by ignoring the critical quality of life improvements possible. You don't need to be a scientist to understand that catching an abnormality at stage 1 versus stage 4 will have very different quality of life implications. So 2 women at different stages of cancer could really be living just as long, but at what cost to them in terms of their quality of life? One woman who's diagnosed early arguably would go far less treatments and have a short, quick recovery and enjoy a high quality of life, compared to her peer who's going through debilitating treatments for years, is chronically overwhelmed and emotionally and psychologically debilitated. So for minorities, the new delayed screening approach not only means that they would be diagnosed at a later, more advanced stage, but also that they would potentially endure a far lower quality of life while alive. Lastly, in terms of cost considerations, the task force claims that it did not consider costs in its final recommendations. Yet interestingly, there was content on its website earlier this year that is no longer there, and it reported that the final modeling for the guidelines was intended to help clinicians, employers, and policymakers evaluate 20 strategies and compare those to select the most efficient approach. And a new intervention was deemed more efficient if it resulted in gains in health outcomes while consuming fewer costs. And even though this content has recently been removed, you can go to a published statement from the task force where it refers to a CISNET study. And the CISNET study, if you go to it, reiterates the same thing, that 20 strategies were explored. And again, only those that were, only those that improved health outcomes while consuming fewer resources and costs were deemed most efficient. So costs were definitely considered. And what this means for minorities is that if the task force guidelines become approved law, the new Start at 50 mammogram screening approach might not provide insurance benefits like preventive care for routine screenings. And that would create a huge conflict of interest, because eliminating screening benefits in the 40s would raise the out-of-pocket costs shouldered by ethnic patients whose breast cancer diagnosis peaks in the 40s, and in addition to them, would discourage them from going for mammogram screenings when they need it the most. Consequently, for all these reasons that we've just discussed, annual mammogram literacy amongst minorities is really crucial so that women in their 40s are not blindsided by the task force recommendations and can have more informed discussions with their own physicians about real health choices. Based on my own advocacy efforts through minority seminars, I realized that only 48% of attendees even realize that malignant tissue changes can occur in a year. And after the seminar, 83% of the women understood the importance of an annual mammogram for a healthy person with no family history. And 97% of the attendees felt that it was crucial for all of them to have a chance to get diagnosed early, if possible at stage 0, to dodge stage 1 true invasive cancer. Although the task force really spends a lot of time patronizingly emphasizing that diagnostic testing induces anxiety, it truly neglects to explain that this anxiety is fairly minimal compared to the subsequent stress endured by ignoring an area that turns out to be a precancer or true cancer. Minority women in the 40s cannot be pacified through ignorance and deserve every opportunity to treat disease at the earliest. As a South Asian woman who was not high risk, I still shudder at the thought of how badly my family would have been affected, how badly they would have suffered had I waited several more years to get my first screening for my next mammogram at age 50. Thankfully, I did not. I have been blessed to be able to raise my daughters, watch my younger one graduate from middle school that year, and then start high school. And I also bought her her promised puppy. I enjoyed seeing my older one's college graduation and her start of med school. Even though this year had started off with a lot of challenges, I was very thankful that I was able to, going forward, enjoy the typical life a normal, energetic 40-year-old woman would have in her 40s. Last week, I celebrated a milestone anniversary with my husband, and we all thought back to 2018. Even though 2018 had started off with tremendous challenges, it also ended up being my favorite year because I felt grateful for the health crisis I had averted. And to celebrate that, my family went for a big trip to Hawaii. We snorkeled, we hiked, and we swam with the manta rays. And participating in such lively activities is what being an energetic woman in the 40s is all about. Hawaii will always be very special to me. Ultimately, when we learn together, we do better for each other and for our communities. I leave you with a few key points. Annual mammograms in the 40s are especially critical for minorities whose breast cancer diagnosis peaks in the 40s. So women should not be confused by the task force guidelines that blanketly ask all average risk women to wait till age 50 to even start screening. We should also remember that 23% of all white women's breast cancers do occur in the 40s. And together we need to advocate for annual screenings so that access is available for all women as part of preventive care in the 40s. So that our mothers, our wives, our daughters, our women might have the same chance that I did to be a breast cancer dodger rather than a breast cancer survivor. Thank you so much.
Oh, thanks, Zara, for sharing your story, and thank you for all your advocacy that you do. We're now going to move to Dr. Brenda Hernandez, who is at the University of Hawaii Cancer Center, And her group is doing a lot of important work studying breast cancer in the unique population that we have here in Hawaii. So she's here to share some of the research they have done thus far. Dr. Hernandez?
Hello, everyone. I'm a bit technically challenged right now, so someone else is going to be advancing my slides. But I'm a researcher here at the University of Hawaii Cancer Center. I'm an epidemiologist, and I'm also the principal investigator of the Hawaii Tumor Registry, which is part of the NCI SEER program. And we've been a registry here in Hawaii since the mid-70s, and responsible for surveillance of all cancer cases and lifetime follow-up. So I'd like to actually show you some of the data that we have on breast cancer, as well as highlight some data published by myself and my colleague, Lenora Liu, who is also on this call. And Dr. Liu does a lot of work in breast cancer and currently has an NCI-funded study on breast cancer to specifically look at some of the ethnic disparities. So just to give you some background, here in Hawaii, in a population of about 1.4 million, we see around 1,200 invasive breast cancer cases each year. It's the most common cancer diagnosed among women, and there are about 148 deaths. Hawaii has among the highest incidence rates of in the country, and you can see on the slides about 138.9 compared to the U.S. rate of 125.9. Next slide. However, when we compare by age, we see that this is broken down by diagnosis under 40, 40 to 49, and 50. Hawaii breast cancer rates are significantly higher even when we break down by age group. So women between the ages of 40 and 49 have a significantly higher rate than the U.S. average. This is based on the SEER9 average, which is representative of the U.S. overall. And the same is true for women 50 and over. The rates of breast cancer are significantly higher than the U.S. average. Next slide. So in contrast to the high incidence, however, fortunately, Hawaii is blessed to have one of the lowest mortality rates in the country. And this is actually true for several major cancers. Next slide. So looking at the trends over the past several decades, there's been an overall increase in breast cancer incidence and a decrease in mortality, very similar to what's seen in trends nationally. And for the most recent time period, in the last decade or so, incidence rates have increased on average about nearly 2% per year, and while mortality rates have declined about 1% per year. Next slide. However, when we look at across our major racial ethnic groups, and here in Hawaii, our major ethnic groups include Chinese, Filipinos, Native Hawaiians, Japanese, and Caucasians, or whites. And so these are the only race groups that we have sizable numbers enough to produce stable incidence and mortality rates. And so the data that I'll be showing you here focuses on those ethnic groups. So when we look at the trends across the major groups, with the exception of Chinese, all the groups have shown an increasing incidence over the past 30 years. And mortality rates have decreased in all groups. However, when you look at Native Hawaiians, specifically depicted in the gray line, we've consistently seen a high incidence, the highest incidence of mortality in Native Hawaiian women compared to all other ethnic groups. And in the more recent years, however, you can see in the blue line that represents whites, and in the yellow line representing Japanese, we've seen that those two groups have shown the sharpest increase in recent years in incidence. Next slide. And so this is our most recent incidence rate, showing that breast cancer incidence currently is highest among Native Hawaiian women, whites, and Japanese women. So statistically, same incidence rates. However, mortality remains and historically has been highest in Native Hawaiian women, followed by white women. Next slide. And if you look at stage distribution, Native Hawaiians, whites, and women in the other groups, which includes all other groups other than the 5 major ethnic groups, share the highest proportion of advanced stage cancers. So about 27% are advanced stage compared to the statewide average of about 24%. And you can see that Japanese women have the lowest percentage of advanced stage tumors, 17%. Next slide. And when we look at incidence, specifically by stage, Japanese women have significantly highest rates of stage 0 in situ breast cancer. And Japanese and Native Hawaiian women have the highest rates of localized breast cancer, generally stage 1 and 2. And for advanced cancers, Native Hawaiians and whites have the highest rates. Next slide. So this shows incidence-based mortality by stage. For localized cancers, statistically, the rates are comparable across the major ethnic groups. But when you look at advanced breast cancers on the right, Native Hawaiians and whites have the highest rates of incidence-based mortality for advanced cancers. Next slide. So Japanese and Native Hawaiian women, when you look by hormone receptor positivity status, they have the highest proportion or a high frequency of hormone receptor positive breast cancer, which is counterintuitive, especially for Native Hawaiian women, where we do see poorer outcomes. But in general, we don't see higher rates of hormone receptive negative breast cancer. So what this does show, though, that when we look specifically at hormone receptor positive tumors, we do see that Native Hawaiian women have the poorest 5-year survival rates among those with hormone receptive tumors. Next slide. So this just shows the incidence broken down by using 50 as a proxy for pre and post menopausal breast cancer. So Japanese and white women have the highest incidence of premenopausal breast cancer, and Native Hawaiians, however, have the highest incidence of postmenopausal breast cancer. And I think that is the last slide, and I'll end there. I guess I can take questions later or now.
Thank you, Dr. Hernandez, and thank you also to Zara Khan. We really appreciate you being here to share your personal story and to discuss the well-documented analysis of the challenges facing minority women. And also mahalo, Dr. Hernandez, for sharing your Hawaii research and the Native Hawaiian women that have the highest incidence of mortality for breast cancer. We'd like to also hear from Dr. Grosskreutz, who is an experienced women's imager here in Hawaii. Could you please tell us what your perspective is on screening for women in Hawaii?
Well, thanks, Lisa. Research in Japan and China has shown that women in those countries have an earlier peak age incidence of breast cancer, but a lower overall incidence of cancer compared with the U.S. And as Dr. Hernandez has shared, women of Japanese ancestry in Hawaii have had an increasing incidence of cancer in recent years, and now their incidence of cancer is almost as high or higher than Caucasian women. And Japanese women in Hawaii also are most likely to develop breast cancer before age 50, according to this research. And why is that? Why are Native Hawaiian women being diagnosed at a later stage and having a worse prognosis? And these really aren't political questions at all. I think everybody would agree that if a physician has patients that are having worse outcomes, that their first question should be to ask why.
And the second question should be what we can do about it.
Exactly, Lisa. So Hawaii does have a higher incidence of breast cancer, as Brenda pointed out, but we have the lowest mortality compared to other states. And yes, we have good doctors, but how probable is it that our treatment in Hawaii is so far superior that that's accounting for for that low mortality in view of the high incidence? And research has shown that we have a higher participation rate with screening mammography in Hawaii than the rest of the country, and that's very likely, the reason for our lower mortality here. And the importance of breast cancer screening and access to breast care just simply cannot be overstated. Research that was published in the journal Cancer using the CISNET models estimated the annual screening mammography from ages 40 to 84 will reduce breast cancer mortality by 40%. And that same research found that if you started screening mammography at age 40, you'd save 100,000 American lives over the course of a decade compared with starting screening at age 50. And Zara has noted that minority women are more likely to develop and often die before age 50 from breast cancer. Additional research is pending, and what it is confirming is that the burden of early onset breast cancer is falling most heavily on minority women. And this is probably multifactorial. It may well be that some of this trend, or much of it, could be due to the fact you've got more younger minority women in the population demographically that are developing breast cancer. It could be due to genetic predispositions. It could be related to issues with access to healthcare and breast cancer screening. But nonetheless, it is a reality, and society just must address this.
I think that, HRS, that we're so grateful that Ms. Zara Khan is here to refocus and highlight these concerns about the USPSTF guidelines, and specifically the statistical issues about screening women between the ages of 40 and 50.
Divergent guidelines are a huge issue in clinical practice. We all see them. The U.S. Preventive Services Task Force guidelines only gave a C grade for screening mammography for women ages 40 to 50. The task force has, in fact, determined that those women developing breast cancer before age 50 are not statistically significant enough to recommend screening for. The many women who develop breast cancer before age 50 would beg to differ on that, and so would their families. Half of the fatal breast cancers are diagnosed before age 50. It's been estimated that between 30 and 40% of the total years of life lost to breast cancer are from women who were diagnosed again in their 40s. What type of healthcare policy would ignore half of the women developing fatal cancers?
Dr. Grosskreutz, could you also comment on the overdiagnosis of the breast cancer?
Yeah, clinically, I have to, reaffirm that Zara's made an excellent point about, the task force's concern of overdiagnosis of breast cancer in women ages 40 to 50. Now, this is not a trick question. If you are really worried about that you're finding too many clinically insignificant cancers, would you limit mammographic screening in elderly patients with a more limited life expectancy, or would you limit it in women ages 40 to 50? Where if you have an undetected and untreated breast cancer that's invasive, you're almost universally likely to be fatal. For women in their 40s, analysis of the SEER data confirms that only 0.1% of screening detected breast cancers are overdiagnosed. 0.1%. And personally, in over 30 years of practice, I've never seen an invasive cancer in a woman 40 to 50 that spontaneously regressed. And to be honest, this is the very, very worst part of being a breast imager. We've all been through it. You have a woman come in, and this happens over and over and over again. Younger than age 50. And they walk in and they've got a palpable breast cancer, and they've got metastatic adenopathy, and you have to go talk to her about that. Often when her family's in the waiting room or waiting out in the car for them, and it's just heartbreaking. It's just heartbreaking, and it happens far too often. And it should stop. And so we need to look at how we can better treat women so that we don't have that tragedy happen over and again.
And I think that, radiologists, we're all wondering, should we really be using false positives as a reason to defer screening mammography in women ages 40 to 50?
Well, the task force seems to be implying that only women 50 years old or older are able to understand and deal with the issues of false positives in breast cancer screening. I mean, I've talked to tens of thousands of women, and performed about 12,000 or more breast biopsies. And, the vast majority of women of all age groups are able to understand and successfully cope with these diagnostic and biopsy-related issues. And just imagine for a minute that there was a sound clinical reason to screen men age 40 to 50. And a government advisory panel decided that these men should not be screened because a 45-year-old man did not have the intellectual capacity or emotional reserves to discuss a possible biopsy with his doctor. I mean, can you imagine? Can you imagine the national uproar on that? So the U.S. Preventive Task Force Presenter Observes Task Force feels that a 50-year-old woman can have a discussion with a physician about false positive, but that a 40-year-old woman might have an attack of the vapors, over the same topic. I mean, what century are we living in? These women in their 40s, like Zara pointed out, they're pursuing careers, they're managing their relationships, they're often taking care of young children, and I think it's both offensive and patronizing, to assume that these women are unable to discuss these issues. And I don't think that radiologists should say that the preventive task force's guidelines are intentionally ageist or sexist or racist, but I mean, you're talking about somebody who grew up in the Midwest and spent 8 years in the military. Even to me, that they seem to be all three of those things. So I know that the ACR and a lot of physician groups have been saying for years that these guidelines are not good medicine and that they're unscientific. But Zara is raising another very critical and important concern here about these guidelines, namely, are they fair? Are they equitable for our population? Do they ensure optimal health outcomes for everyone? And the answer to that is that the task force guidelines discourage the screening of women aged 40 to 50, which adversely affects all women, but the greatest negative consequences for minority women. So in conclusion, we have to do a better job. We need more research, on these issues. So I'm grateful for the University of Hawaii Cancer Research Center on this. We need better cohesive screening guidelines. And we also need to make sure that all women have appropriate access to breast cancer screening. And Hawaii, unfortunately, has a huge and chronic physician population that's approaching 50% on the neighbor islands. And I'm very concerned that the decreasing referrals for breast cancer from my clinical colleagues is going to increase Hawaii's breast cancer mortality forward. And it's a local issue, but it's another thing to keep in mind. And thank you.
Agreed. Thank you, Dr. Grosskreutz, for your comments. I think that this panel has really framed well the important critical questions surrounding screening guidelines. And I would like to hear from our HRS legislative liaison, Dr. Loris Wade, about ideas for solutions here in Hawaii.
Thank you to Zara Khan once again. Zara Khan has issued what I would call a clarion call, which is a strong request for action. And I focus on one of her statements, which I apologize, it's not a direct quote, but I think it catches the gist of what she says. And that is that minority women in their 40s should not be pacified by institutionally fostering ignorance of the benefits of mammography. And that, in a sense, is what our government has done. It bears reemphasis that mammography screening for breast cancer in women ages 40 and above is one of the major healthcare advances and successes of the last 40 years. It has helped reduce breast cancer mortality rate in the United States by nearly 40% since 1990. Unfortunately, in 2009 and again in 2016, the United States Preventative Services Task Force released breast cancer screening guidelines, which assigned a C grade to screening mammography for women ages 40 to 49 and a B grade to women ages 50 and above. And for women ages 50 above, only really approved mammography every other year. This remains a significant departure from breast cancer screening guidelines that were in place 10 to 15 years ago and that were advocated by leading clinical organizations for women's health. Our issue is that if task force recommendations were recognized and enforced for purposes of the Affordable Care Act coverage mandates put in by Obamacare, then individual and group insurance plans would no longer be required to cover annual mammography with no cost sharing for millions of women ages 40 to 49. More importantly, United States Preventative Task Force guidelines recommendations have resulted in a fragmented set of screening guidelines based on specialty societies' interpretations of available literature and task force guidelines. So they vary significantly. The federal response to protect screening has been a series of stopgap legislative measures. Most recently, the Protecting Access to Life-Saving Screenings Act of 2019, or PALS Act. PALS Act is set to expire on the 31st of December 2020. This leaves women in the United States vulnerable to losing screening mammography services. In the state of Hawaii, Hawaii women are essentially under continuous threat of losing such screening should federal legislation be allowed to lapse. And considering the levels of ongoing legislative dysfunction, I think that that's a significant risk. As such, the Hawaii chapter of the American College of Radiology has drafted legislation based on similar legislation in Missouri that is committed to ensuring all women have access to breast cancer screening, regardless of both age and ethnicity, provided such screenings are requested by licensed medical practitioners. That draft is going to be made available for review on the ACR website. And while written to apply at the individual state level, and certainly it can be adopted by other state chapters, our hope is that this legislation can serve as a model for national legislation. Thank you.
Thank you, Dr. Wade. I guess we will open it up to some questions. I'll take a look here in the chat box. And I see that there's a question about the difference between benign tumors and stage 0 cancer. The question is from our audience that does an oncologist differentiate between the two? Is it through biopsy? Who would like to take the answer? I'm happy to.
This is Dr. Smotherman. I'm happy to answer.
I was just going to volunteer you, Dr. Smotherman.
Yeah. So stage 0 breast cancer is duct carcinoma in situ. So as Ms. Khan accurately noted, this is breast cancer, but it has not broken out of the ducts and invaded the tissue. So it is very, I mean, of course, there's always a continuum between normal tissue, atypical cells, and then duct carcinoma in situ, and then eventually invasive cancer. But a pathologist with a biopsy can tell the difference between this, and it does require treatment, as Ms. Khan noted. Has to be excised, may need to have radiation or other therapies. So anyway, so that's the difference. But great question. And it is differentiated on a biopsy.
I would volunteer anyone from the audience who would like to make comments about the concept of overdiagnosis in young women. I think that's a key point. It's one thing when you find a potentially lethal cancer in the person whose life expectancy is only 3 to 5 to 10 years, but when the life expectancy would otherwise be 20 or 30 years. Anyone in the audience want to comment on that from either personal or professional experience?
Well, I can certainly jump in again. Like Scott, I have seen in my career many young women who had breast cancer, and sadly, many in their 40s who have died, including one of my med school classmates who wound up being one of my patients and who died, leaving a very young child. Just absolutely tragic. I think that, I have patients who I have diagnosed in their early 40s who have come in pregnant and who then, we see them over the course of their therapy, bringing in the baby and unfortunately having a very aggressive cancer and never having been screened. And I think that all of these are just absolutely heartbreaking, and they make such an enormous impression on you. I mean, Louisiana, unlike Hawaii has a large African-American population who also are at increased risk for breast cancer. And in fact, the American College of Radiology was really the first group in our most recent guidelines on screening to recognize that group as being at high risk, as are, for instance, Ashkenazi Jewish women. I think my colleagues and I, living in New Orleans and in Louisiana, have always been really strong advocates for beginning screening at the age of 40, which does benefit all women. I don't mean to suggest that if we only were to screen minority women at the age of 40, that would get us where we need to go. Really, all the studies show, and all of the societies recognize, that the greatest decrease in breast cancer mortality is to begin screening in all women at the age of 40. But I do think, as everyone has noted here, many of our minority women are put at a particular disadvantage by things like the USPSTF guidelines. I could keep going on because I have many, many stories in my now long career, but those are just two that always really come back to me and resonate with me.
I noticed that we have one medical student who's commented that in medical schools, the USPSTF guidelines are taught. If there are any medical educators in the audience, we'd certainly love to hear from you about teaching. Yes, unfortunately, you do have to teach a guideline that exists that's in print, but it's also possible to teach the right guidelines, the better guidelines, the proper guidelines, and why they are different, why they differ. Medical students can handle that. Any medical educators want to speak to that?
Johnson, this is Geraldine. I would love to add a comment.
How are you, Dr. McGinty?
I'm good, and thank you for this incredible discussion. And Jolie, who asked the question, is one of my mentees, so thanks, Jolie, for that. But I think that speaks to the importance of having radiology electives and radiology education in med school, so that we can not only encourage the best and the brightest to choose radiology, but also tell this very important story about how we can take better care of our patients through population health screening.
And I will also say that there are lots of, for medical students or anyone who wants to become better informed, the ACR has lots of resources. We have decision aids both for patients and for physicians, which I think for somebody who wants to just really get a very quick understanding of the differences, Scott went through them very eloquently, but of the real impact in lives saved if you start at the different places. So I think that'd be a great place for a medical student to start, and then there are references on all of those if you want more information. And Society of Breast Imaging as well.
We do have a fair amount of University of Hawaii medical students on the conference, and I'm glad that they are able to join us and participate. I'll just remind all of our young physicians, especially the students, to consider membership with the ACR. If you want to learn ways to become an advocate for things like this, for screening for women between the ages of 40 and 50, that's a great place to start. And our young physicians and our students, you are the ones that are going to be carrying this forward. So please consider your membership.
I also see that one of our commenters mentioned interest in involvement with advocacy and improving access to breast screening. And I think that's a critical function that radiologists can perform as members of the community, from the barbershop to the beauty shop, to the church to the synagogue. That's an important vehicle, but also to the State House, as Dr. Wade is pointing out. Recent legislation in Missouri and proposed at Hawaii is arguably some of the most potent advocacy that we can undertake. Loris, you want to comment about your experience as an advocate at the State House?
Oh, I mean, we have a responsibility, I think, as citizens to see the world as it is and try and move it to the way you would like it to be. Hawaii has an array of healthcare delivery challenges that are not unique to radiology. Dr. Grosskreutz and I have been heavily involved in an ongoing and growing physician shortage on the state of Hawaii. We've had extensive dealings with the legislature on that particular issue. It's been a learning process. I think the level of knowledge on the part of most legislators or people that are in the executive branch is relatively limited when you start getting deep into the details of the issue at hand. Most of the time that you spend is educational, so that you end up trying to get your listener on the same page as you are in terms of a fact set, and then you try and lead legislators to what you think are an appropriate legislative response. You know, we're very accustomed, I think, as working with other physicians and other people in the healthcare field. We speak a unique language amongst ourselves, that the moment you start dipping your toe into legislative matters with people that don't have the same background, that the lack of speaking a common language can get in the way of legislative progress. So anyone that chooses to get involved in a legislative effort, you need to be careful about trying to frame your issues in a language that the listener can understand. In this particular case, what I find very interesting about Zara's point of view is that she's looking at this from a civilian point of view, if you will, and that's where it has value. And the fact that she's taken the time to dig into some fairly deep and complicated issues regarding epidemiology and ethnicity and how it relates to this particular problem is very valuable, I think, as clinicians. It's almost like listening to your patient. Listen to what they say so that you can then translate it into your own language, digest it, and then find the use for it. So I'm feeling energized by what Zara has put out into the world. I have had a long-term disdainful relationship with the United States Preventative Task Force guidelines ever since they basically came out. It's been the subject of some expletive-laden conversations amongst radiologists that I've known over the years. And if this unique and important point of view helps us drive a stake through the heart of the United States guidelines with respect to screening mammography, then I might be the second happiest person on the panel.
This is Scott here, and I just would really like to thank Zara for the clarion call, bringing this issue forward. It's just been tremendous, and you've got such a moving story, and you're so spot on in the way that you talk about this. And we're also grateful in Hawaii that you've offered to help us lobby for this new legislation. And it's just a pleasure to work with folks that, again, are excellent advocates. Dr. Wade just got here a year ago, and already the governor summoned him over to fly over to Oahu to meet in person to discuss health policy. So it just goes to show if you have a gift for that, then that is so important, because unless you stand up for the practice of medicine and your patients, if you don't do that, you can't assume that anybody else will.
Thank you so much. I just wanted to comment on that a little bit, that being a numbers person, I think, and all of you also coming from a data background, you can take any number and splice it in an angle that fits a certain motive. And one of the things that was very clear to me as I was sifting through the data to come to the truth of how important mammograms are for women in the 40s was the number that 1 in 6 breast cancers are detected in the 40s. So no matter how you cut all the other numbers, just that fact alone should make everyone pause and think that it's not appropriate to stop mammograms in the 40s for all women. The other point that really struck me when Dr. Wade was talking about our impression on the world, is that the world looks to us as leaders for medical guidance. And we need to be really careful how the rest of the world processes this information. I just recently started looking at what the international data is like to kind of test the waters on ethnicity across the globe. It's so interesting that Turkey recently did a lot of studying and decided that Turkish women who are considered white, so not all whites are the same either, 47% of all breast cancers diagnosed in Turkey occur before the age of 50, so in the 40s. And they have changed their guidelines and said very clearly that breast cancer here is occurring a decade earlier compared to white women of other descents. And so they are going to start at 40. I'm of South Asian background, so I looked at South Asia. Interestingly, Pakistan has the highest incidence in all of Asia. And over there, we also have cultural issues where because of modesty, lack of healthcare, people really are uninformed. So I really feel an obligation to keep the effort going. You can't just take minorities who don't know better and ignore them. You have to help them and help them understand that this is an opportunity for them, because in the 40s, we're in the midst of our lives. And the same thing in other regions. So I thought it was very interesting when Dr. Wade spoke about how hopefully, this effort will continue and make an impression on the world, that we really have an obligation to the world to do the right thing also. Thank you so much for having me.
We have more questions, or comments, I should say. Let's see.
I noticed that we have a comment from a gynecologist in the office who encourages all of her patients to get mammograms. You're welcome to. Jeremy, can you give her a raise hand or? All right. There's an invite to speak for Dr.
She in the chat.
Yes,
Dr.
Dr.
Or Q&A.
Uh-huh. But that certainly emphasizes the importance of allies in the clinical specialties, gynecology, family practice, internal medicine, that we as radiologists, whether it be tumor board or grand rounds, need to be advocates between our specialties and with our clinical colleagues.
I think one really important point was raised by Zara, and that there actually are, as we all know, in breast imaging, there are challenges in screening younger women, often is related to the density of breast tubes. Also, a challenge for Asian women who tend to have denser breast tissue than other ethnic groups, and that's been shown in some of the data and some of the studies that it's occurred in Hawaii lately. But the answer is then not to ignore that portion of the demographic that requires screening. It's to improve your screening. And as Zara points out, tomosynthesis has been such a valuable tool. We've gotten that made widely available in the state of Hawaii over the last couple of years, and that's just one of these things that if you have it available in your community and you're a younger woman, that's something that you and your physician should be talking about. So improving the quality of your screening is something we all work on. The American College of Radiology has been a leader in this area for so many years, and we're grateful for that. And I just don't have any doubt in my mind that our screening techniques will continue to improve.
I see that Dr. Inoue is there if she wanted to comment. She had put some good comments in the chat box.
Right.
Hi. No, I just wanted to say I totally agree with Zara. I think it was a great talk. And I mean, I used to start mammograms when in those days you could start them at 35, and actually discovered about 5 people in those years that did end up as far as having breast cancer. And of course, we diagnosed them early, and they're still alive today. So definitely 40, I tell my patients every year, I tell them exactly what you say about the task force. And, you know, I will say that just like you said, I have many patients who have a good mammogram as far as nothing wrong with it, benign. 1 year, next year they have, you know, the need for a biopsy. So, and when people look at the old mammogram, it's not as if something was missed. It was just that it went ahead and formed in the meantime. So I totally agree with you, and I think that it would be great for us to go ahead and make sure that women are able to go ahead and have access to this. So thank you as far as for going ahead and being part of the webinar.
Thank you for having me. My pleasure.
There's some commentary on the Q&A page from Teresita Macarol, which indicates that she had her first breast cancer incidence at the age of 44 and had recurrence at the age of 50. She then goes on to comment that she's going to encourage her 34-year-old daughter to go and send her a mammogram, which you know, for those who may be lay people on listening to the conversation, American College of Radiology has long-standing recommendations to have baseline mammography at the age of 40 in asymptomatic women. I think most radiologists think that, along with the American Society for Breast Surgery, that 2 sets of recommendations together constitute probably the strongest set of recommendations. We're moving towards bringing in various genetic risk factor assessments in order to modify those recommendations, and that is ongoing work. But as the recommendations stand now, it's important for folks like Teresita Macarol to understand that we accelerate those recommendations in the first degree relatives of women who've had breast cancer. So American College of Radiology recommendations would indicate baseline screening for Ms. Macarol's daughter at the age of 30. So she's already a bit late. And so I would encourage anyone that had a first degree, either a sister, a mom, or a daughter with breast cancer to obtain their screening mammography. But also emphasize, as Zara so correctly pointed out, that only a limited percentage of women actually develop breast cancer do have that first degree relative with breast cancer. So it's not a reason to not get a mammogram if it doesn't run in your family. And I've heard that over and over from women who've come and seen me, and we have to discuss a positive biopsy result, and they're surprised because no one in their family ever had breast cancer. And there is this feeling out there in the population that's the overriding thing that should be driving decisions whether to not get mammography, and that's simply untrue. So get your screening mammograms.
And I'd just like to share that the American College of Radiology and the American Society of Breast Surgeons also are recommending that women at age 30 be assessed for their risk. And if they are high risk, then additional screening is well indicated well before age 50. You know, and that might be MRI or mammography, but women should be aware of that. And we're close to wrapping things up here, but I just want to take a moment to thank everyone. I would like to thank Dr. Lightfoot and Dr. Smetherman and the American College of Radiology for hosting this important national conversation. I'd like to thank Dr. Hernandez, and I would like to most especially thank Zara Khan. I just think it's been an awesome opportunity to hear your story and your concerns. And from Hawaii, aloha.
Thank you. Mahalo.
Aloha.
Mahalo, everyone.
Mahalo.
Aloha.
Yes, aloha. Thank you so much for including us. This was wonderful.